In the upcoming few slides, we will discuss the clinical presentation and the ultrasound and radiographic findings of hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis is acquired hypertrophy of the circular muscle at the pyloric region. The etiology is unknown. It's fairly common. It presents in 1 out of 500 live births, more common amongst male than females, and it's more common amongst the firstborn. So the typical patient would be a 2 to 9 week old firstborn male with non-bilious projectile vomiting. It is fairly rare about 3 months, and it's very uncommon amongst preemies as well. The imaging study of choice for hypertrophic pyloric stenosis is an ultrasound. What we are looking for on ultrasound is an elongated pyloric channel, which should measure longer than 16-17 millimeters. And we also look for thickening of the circular muscle. Here it is important that we measure on the muscle wall and do not measure the echogenic mucosa. So we measure only the hypoechoic muscle, which should not measure thicker than 3 millimeters. Also, the ultrasound techs would try to feed the baby under ultrasound and watch if the pyloric channel opens up. So the top image represents hypertrophic pyloric stenosis, and the inferior image demonstrates opening up the pyloric channel, where you can see tiny, echogenic gas bubbles and fluid passing through. And here you can see that the hypoechoic muscular layer without the hyperechoic mucosa is actually thin. They used to say that the easiest way to remember the numbers for hypertrophic pyloric stenosis is pi 2.14, meaning that the muscle layer should be thicker than 2 and the length should be longer than 14 millimeter. If you use pi, you're going to probably overmeasure pyloric stenosis a lot. So we recommend that you use 3 millimeter for muscle thickness and 7 millimeter for the length of the pyloric channel. If the ultrasound is negative for pyloric stenosis, the ultrasound technician is instructed to look for other things that can cause the patient's symptoms, such as SMA-SMV inversion, which you can see with midgut volvulus, and they also need to look for hydronephrosis. An upper GI exam is not indicated for pyloric stenosis. In the rare case that it would be performed, what you expect to see is a grossly distended stomach with kind of like a warm sign, where you can see the stomach trying to squeeze the liquids through the pyloric channel, and a string sign where there is only like a little trickle of fluid going through the pyloric channel. The treatment for HPS in the US is pylorectomy. However, in Europe, they just use hydration, electrolyte replacement, and in general, non-operative treatment.